Assalamu alaikum. I hope everyone is here.
عليكم السلام ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته.
Okay, we will start now. Good morning, ladies and gentlemen. We are happy to have you with us in the second day of a Chronic Disease Update Symposium. We will have 4 presenters today with our utmost gratitude for their participation and great effort. Each presenter will be presenting for 40 minutes and there will be 10 minutes for discussion. Our first speaker today is Dr. Suha Abdul Jawad, Professor of Nutrition, Food and Nutrition Consultant, Taiba University. She will be presenting benefits of healthy lifestyle and role of food alternatives. So welcome, Dr. Suha.
السلام عليكم ورحمة الله وبركاته. صوت واضح؟
واضح دكتور واضح.
السلام عليكم ورحمة الله وبركاته. Suha Hashim Abdul Jawad will discuss today for the role of food alternative in chronic disease and benefit of healthy lifestyle. طبعا أشكر دعوتي للتحدث عن هذا الموضوع وشاكر اللجنة المنظمة والكل القائمين على نجاح هذا المؤتمر الرائع. Health is not simply the absence of sickness, the Hannah Green. Have you ever thought about how your health lifestyle affects your health? The role of food alternative in chronic disease and benefit of a healthy lifestyle. 83% of people had at least of chronic disease. Decrease in chronic disease morbidity was followed by increase in health lifestyle factor number. For the 3 chronic disease, hypertension, diabetes, or dyslipidemia, a lack of physical activity presented 1.231 times, almost 95% higher risk than being a physical activity. A health lifestyle is one of the including balanced diet, plenty of exercise, and a good night's sleep. However, we all know that life isn't always easy to maintain. For example, if you have trying to lose weight or get in shape, but find yourself feeling tired or out of breath of the end of your workout routine.
دكتورة سعد اسمعيني
أيوة.
يعطيك العافية.
أهلين.
ممكن عرض الشرايح بالله؟
كيف؟
ممكن تضغط على علامة عرض الشرايح اللي تحت علشان يكبر البرزنتيشن عندي.
طب أنا عملته.
لا إحنا طالعين عندنا نص دقيقة. أضغط
كده؟
أيوة.
كده ظاهر؟
دقيقة بس دكتورة.
ها؟
لسه دقيقة.
لسه؟ أنا جربته قبل لا أبدأ. كده؟
أيوة كده ممتاز دكتورة.
أوكي. However, we all know that life isn't always easy to maintain. For example, if you have trying to lose weight or get a shape, but find yourself feeling tired or out of breath at the end of your workout routine because you haven't been eating enough calories throughout the day or week, then it may be time for and adjusting how much time you spend exercise each day. The American Heart Association recommended eating no more than 30% of your calories from added sugars each day. This also can do by choosing low sugar snacks such as a fruit and veggies instead of candy or soda. When you unhealthy lifestyle, you have a risk of heart disease, diabetes, and high blood pressure. A diet rich in food that are higher in saturated fat, and cholesterol increase the risk of heart disease. The is true for diet rich in fruit, vegetables, whole grain, and fish. In addition to helping with weight management issue related to diabetes mellitus type 1, eating healthy vegetarian diet is associated with low blood pressure level compared with diets higher in animal products like red meat, which contain high amount of fat. The lower risk of stroke, osteoporosis, depression, Alzheimer's disease, and many others. A healthy diet and lifestyle can help prevent many chronic disease, including stroke, osteoporosis, depression, and Alzheimer's disease. Stroke is the third leading cause of death in the United States, affected on in 4 adults for over age 65 and a similar number of younger. Also, when you're younger, have blood pressure or diabetes, it may be a risk for also the stroke. Stroke also contribute to heart attack and other cardiovascular disease problem that you can lead to heart failure. Osteoporosis also a disease that causes when bone is become weak or brittle. When you avoiding chronic disease must be management or changing your lifestyle. As you get older, it becomes harder for you to maintain healthy bones if you don't take a proper step to prevent them from getting weaker over time. You can also reduce your risk by eating plenty of fruit and vegetables rich in calcium every day, as well as getting enough exercise also regularly. This will be keep up with any loss in bone mass through aging. A lot of clinical and nutritional research has been proven the relation effect and impact of healthy and dietary pattern in preventing chronic and acute disease. Diet and health implication for reducing chronic disease, 2021, lifestyle and related risk factor for chronic disease, 2021, the role of diet in chronic disease, also this published in 22, diet, nutrition and preventing of chronic disease, also published in 2003. The role of healthy life in prevent chronic disease among the adults, also this presented 222. The association between a combination of healthy lifestyle and the risk of hypertension and also dyslipidemia among adults events from noted of China. This is published in 22. Association between family history of major chronic disease and healthy lifestyle in China adults is also, this is 2018. Age, all manage and prevent of hypertension through lifestyle in young. This is also published that one in 2022. Also impact of healthy lifestyle in cancer risk in China. This is also present in 2019. We'll see in this slide how can a recent study which is published in the 2022, a recent study showed the people with diabetes exercise even at low level effectively have prevent diabetes related complication, and always remember that less is better than less than less. Healthy behaviors. When you talk about healthy behaviors, you know, this is 5 healthy behaviors are known to positively influence health. When you ask people, always put them in order of importance. Which would you say is important for good health? Which would you put second or third? Which be also least important? Let's talk a few minutes and choose where to rank each factor. Don't smoke, eat a healthy diet, maintain a healthy weight, exercise regularly, get sleep. Which healthy behavior are most important? Don't smoke, healthy weight, also exercise and quality sleep, eat healthy diet. We hear more about certain behavior than other. We know that begin at a healthy weight, eating right, and regular exercise are important. If you smoke, you should quit. You may say that begin at a healthy weight is most important because it's related to a few of other factors. The trust that these factors have effective in health. One factor doesn't outrank the other. Researchers look at these factors saying that what's important is that you have communication of this behavior, not that you pick the most important one and focus on that. A person may be at a healthy weight, but if he or she smoke, doesn't exercise, has a triple diet, doesn't get enough sleep, overall health will suffer. On the other hand, an overweight person, several of other behavior may experience increased wellness, carrying a few extra money. We'll talk today about how many of these 5 factors will need to experience to create this impact of health. This is strong evidence that practice complication of these 5 healthy behaviors to lengthens. One study found a 66% reduction in all-cause death from all cause among people who practice 4 or more of the behaviors, while another study found reduced risk with 3 factors. The main point in this, the more health behavior your practice, the better your health. The combined effect of this healthy behavior is stronger than practicing 1 or 2 alone. Stop smoking. Tobacco is the most preventable cause of death in the US and all around the world. Also, causes for cancer, death-related smoking, cigarettes, risk factor for lung cancer associated with other type of cancer, increasing risk of heart disease and chronic lung disease, increasing also for all period disease, quitting the best gift you can give your and loved one. According of Surgeon General, quitting smoking is the single most important step a smoking can take improve the length and quality of his or her life. As soon as you quit, your body began to repair the damage caused by smoke. It is best quit early in life, but even someone who quits later in life will improve their health. According to the recent study, quitting smoking can show health benefits in a little as a few weeks. This study showed that a college student who smoked and didn't have any chronic illness, this all symptom caused by smoking within a week of quitting smoking. This means that quitting will be benefit your health in day, not decade. Quitting will always important, improve your fitness. Also, the cigarettes are expensive. It's big cost more than 5 or 20, maybe 25 real. Smoking are big per day, added to maybe more to 1,000 each year. What will do? Stop smoking. The role of food alternative in a chronic disease. Food alternatives are low in calories, rich in fiber and nutrients, can help you control your calories intake. Foods such as nuts, seeds, beans, pea, and all of high in protein. This also contain antioxidants. The antioxidant that can help you fight of free radicals that cause inflammation in body. Food like avocado is very important because improve heart health by reducing LDL cholesterol, also helping reduce fluid retention or slowing association with high blood pressure of diabetes mellitus type 2. Healthy diet must be balanced calories. Enjoy your food, but eat less. Avoid oversized protein. When I discuss about my plate, the eating pattern recommended for most American, it's fairly new. There are 3 main ideas behind the my plate graph. The first idea is balanced calories. Must be balanced calories. Also, the second concept in my plate is the increase certain type of food in the diet. Always read blue on side and relate them to the my plate graph. When you have your plate fruit and vegetables, always remember, make at least half your grain whole grain and switch to fat-free or low-fat. For example, 1% fat in the milk. Food to reduce, choose food with lower sodium. Drink water instead of sugary drink. The third concept to reduce certain type of food, always read to it. Compare sodium in food like soup, bread, and frozen meal, and choose the food with lower number. My plate is a simple sample for picture that you can use to guide your healthy eating habits. All recommended for nutrition must be take 3 meals and 2 snacks over the day, and must be you drink a lot of water, more than 2 liters a day. Always reach in the maintain a healthy weight. Extra weight increase risk of type 2 diabetes, hypertension, heart disease, and stroke. Also, some type of cancer, problem sleep, and not good quality sleep, osteoporosis, and all bone problem. It is being well established that carrying extra weight has negative effect on health, even if you haven't been diagnosed with the condition of this slide. You likely know that extra weight affected how you feel or your sense of well-being. We often think of the increasing chronic disease and cancer rate that comes with being overweight, but carrying extra weight also increase risk of sleep apnea and osteoporosis. Must be always remember healthy weight. Small weight loss matter a lot of 5 to 15% of body weight can improve health. There are good news. You don't have to lose a ton of weight to see health benefits. Studies show that small decrease in weight can help reduce risk of chronic disease like diabetes. If you have already been diagnosed with diabetes, losing a little as 5% of body weight can help you manage blood sugar level. For example, if a person weighing 200 pounds will health benefit from losing a little as 10 pounds, 5% of 200 pounds. Of course, losing more weight to reach the health BMI range offer additional health benefit. The main point there is that losing just a little is helping and good jump start if your goal is to lose more. Where you wear, your weight matter. You may have heard people describe have pear shape today. Always today ask about body shape. When her people describe as have a pear shaped body or a body shaped like an apple, when it comes to health, where you wear extra body fat make a difference. All fat is not created equal. Risk for disease, like heart disease, increase when extra fat is carried around the mid. So when around the midsection, like an apple, in comparison, fat carrying the hip and lower body, like a pear, it's associated with lower risk. The problem not for body shape, also for the fat on the inside. It is often said that what in the inside also what that count. The absolutely true, even with where it carry extra body fat. Some people may be carrying hidden fat. Some fat you can see. This is called subcutaneous fat. But there is another more diagnosed type of fat, visceral fat, which is underneath the muscles surrounded your organ. Carrying extra fat, that must be, it's Pele puts you to increase risk for diabetes and heart disease. But studies suggest that exercise, even you don't lose any weight, can help to reduce this risk, reducing inflammation. Obese people have higher level of circulating inflammatory marking like CRPC protein react, which produce and secreted by a fat tissue. The inflammation target disease associated with also metabolic disorder like diabetes and also heart disease. You can literally look slim, but we always be fat on the inside. Stress can be factor affected storage of these visceral or arterial fat in the body. Visceral fat is harder to lose than substituting fat. Substituting in the surface fat can pinch. This always visible on the inside, invisible or vicious. Do more exercise. Do more exercise. 100 minutes a week of great aerobic activity, strength training at least 2 times per week, balance exercise for senior adults. The minimum exercise recommendation for adults is 150 minutes for moderate. Must be activity make 2 or 3 times half an hour in a week. When you walk half an hour in a week. If you have exercise, 75 minutes a week is required. You can break the exercise also down into chunk as small as 10 minutes, as long as the cumulative amount over the week adds to be 150 minutes. You can a good shape run in it. In addition to exercise that increase your heart rate aerobic, you always should do strength also train at least twice a week. All studies suggest the exercise be help your health and get healthy life benefits. Sleep well. 7 to 2 hours a night for most adults. Negative health affected for oversleeping, too little sleep. Sleep affected your health in a big way. There is some evidence suggests that people eat more when they are asleep, meaning that not getting enough sleep can lead to weight gain. Most adults need 7 to 8 hours night for best amount of sleep and also quality sleep. Although some people may need as a few as 5 hours or as many as 10 hours for sleep each day. Also, sleeping too much has been linked to negative health effects like depression and heart disease. A lot of studies have found that people who sleep 9 or more hours a night have also higher death rate than people sleeping 7 to 8 hours a night. No specific reason for this because nothing or no reasons for this one. Too little hours of sleep can weak the immune system and cause memory problem and depression. A healthy lifestyle is the one that supports balanced diet, regular exercise, and reduce stress. The aim of healthy lifestyle is to improve your overall health and well-being by reducing the risk of chronic disease. A healthy diet, including plenty of fruit and vegetable, whole grain food like brown rice or pasta, beans, nuts, seeds, fish twice a week. Also, low saturated fatty dietary produced such as a milk, but no cheese made from milk. Lean meal like chicken breast or turkey breast are good also choices for protein too. Regular physical activity should be also do into daily life where possible. Walking for 30 minutes every day, you can help reduce also weight gain due to increase in energy when combined with eating well-balanced meal through the day. Stress management techniques such as the medication can also help reduce stress level, which also can contribute toward maintenance healthy lifestyle. Finally, today, world changing and the food that we eat is not what is used to be. We have access to many alternatives today, but very few of us know about them or how they can benefit our health. The role of food alternative in chronic disease benefit of healthy lifestyle are both important topics which need more researchers and attention from scientific around the world. Thank you for listening and thank you to be attend in this important conference, Dr. Suha Abdul Jawad.
Thank you very much, Dr. Suha. Really a comprehensive lecture. We have some questions for you from the audience, Doctora. The first question, what is the best dietary modification for diabetic patients who are at high risk of developing cardiovascular disease?
Must be when I, when decide to make any good food for diabetes and hypertension, must be used a plan for a case study for the patient. Some people have diabetes, diabetes type 1. Some people have diabetes type 2. Always, when you use diet for all diabetes and hypertension, must be used low salt, low fat, and low sugar.
Okay, thank you, Doctor. We have another question. Does omega-3 capsules have a role in preventing chronic disease occurrence?
Yeah, omega-3 is have a good benefit for Alzheimer and heart disease, and all topics and researchers know that the benefit, for the coronary artery disease and also for Alzheimer and for also thinking. When you use omega-3 must be used by what advice for the doctor and also consultants. Use the omega-3 from nutrition source. I mean fish and salmon and sardine, all the omega source for omega-3. The omega-3 nuts, only omega-3, can use also omega-6 and also omega-9. And this, I think it's the fatty acid also reduce blood triglyceride level, also appear to slight improvement of high density lipoprotein, cholesterols, also increase of level of low density lipoprotein like LDL cholesterol. The fish oil is a good source of omega-3.
Okay, we have another question, Doctora. Is there specific herbal supplements approved to decrease the level of blood glucose in diabetic patients?
Can you repeat
Yes.
again, please?
Is there a specific herbal supplement approved to decrease the level of blood glucose in diabetic patients?
Okay. When use herbal supplement for the diabetic any patient, always what the benefit for the herbal. When use herbal must be I know what the problem before happened for the diabetes. The benefit for diabetes must be take any supplement from outside, like omega-3 is the good benefit. Also, when you use any supplement like what they say, always medical of moderate global demand. In fact, you know, the good herbal like omega-3 for diabetes. Also, when you use
Yes, Doctor. Okay, thank you very much, Doctora. It was a great pleasure having you with us today. Thank you so much. For our next speaker today is Dr. Suad Fadl Al-Mawla, Assistant Consultant Family Medicine at National Guard Hospital. She's going to speak to you about what's new in obesity management. Welcome, Dr. Suad.
Thank you, Dr. Ala. Okay, the screen is shown for you, the presentation.
أيوة دكتورة.
تمام. السلام عليكم، بسم الله الرحمن الرحيم، والصلاة على سيدنا محمد وعلى آله وصحبه أجمعين. This is Dr. Saad Fadl Al-Mawla, Assistant Consultant Family Medicine, National Guard Hospital. Today I'm going to talk about what's new in obesity management. Our objectives for today is introduction, updates in pharmacological management, and updates in pediatric and metabolic surgery. As we know, regarding the WHO, the definition of obesity and overweight is defined as abnormal or excessive fat accumulation that present a risk to health. WHO classified the weight status into normal weight, underweight, overweight, and obese. The normal range is from 18.5 to 24.9, as we know, and if it is less than 18.5, it's considered underweight, and if it is from 25 to 29.9, it's overweight. But it is above 30 kilogram per square meter, it is obese, and we have 3 classes for obesity. In children, we depend on the BMI for as a percentiles. The normal range is between the 5th and to be less than 85th percentile. But it is less, if it is less than 5th percentile, it's underweight. And if it is ranged between 85th to 95th percentile, it is overweight. But if it is above 95th percentile or greater, it is obesity. Okay, is obesity a chronic disease? Actually, in 2013, the American Medical Association designated obesity as a chronic disease. And in 2014, the American College of Cardiology, the American Heart Association, and the Obesity Society published a clinical guidelines for the management of obesity in adults. And in 2016, the American Association of Clinical Endocrinology have published evidence-based clinical practice guidelines as well. What about the prevalence of obesity in Saudi Arabia? In 2013, the prevalence was 28.7%. But in 2016, this prevalence has been increasing to up to 34.3%. For this new study article have been published in June 2020, showed the prevalence was 24.7%, which means the prevalence is decreasing compared to 2018 and 2013. And this could be the policies which have been applied by Saudi Arabia to prevent obesity. As they set a goal, the MOH set a goal in 2014 to reduce the prevalence of overweight and obesity by 10% between 2014 and 2025. And this schedule shows some policies could be the reasons for the decreasing the prevalence of obesity and overweight. For example, the sugar sweetening taxation, the nutritional labeling and calorie on the menus, the marketing restriction for unhealthy food, and maybe the school-based policy for initiation of exercise in schools and media campaign could be the reasons for decreasing the prevalence of obesity among Saudi adults. Let's talk about the anti-obesity medications. What's new? As we know, the indications of anti-obesity medications, if the BMI above or equal 30 kilogram per square meter, or if the BMI is equal or more 27 kilogram per square meter, plus obesity-related disease, or for whom dietary and physical activity has not been successful. Most of anti-obesity medications working by increased energy expenditure or decreasing energy intake or decreased energy absorption. Okay, this is an important question. When to consider anti-obesity medication is effective? If patients able to lose weight 3 to 50% of the total body weight after 12 weeks of therapy, it is considered effective. And when patients able to achieve stabilization of the weight, if that's a clinical therapeutic goal, it's considered effective. But if minimum weight loss goal has not been achieved by 12 weeks, modification or discontinuation of therapy is recommended. Most of anti-obesity medications are category X group. That means should not be prescribed for any pregnant, breastfeeding, or trying to conceive patients. And pregnancy test should be ordered in any female of childbearing age before starting the anti-obesity medications. Okay, what are the FDA approved anti-obesity medications for long-term use? In 1992, Orlistat has been approved, and in 2012, a combination of phentermine and topiramate has been approved for long-term use. Long-term use, I mean more than 12 weeks. We can use it for more than 12 weeks. In 2014, we have naltrexone and papropion, and in 2014, liraglutide have been approved as a group of GLP-1 receptor agonists, and recently semaglutide has been approved for anti-obesity medication in 2021. For semaglutide, it is a GLP receptor agonist. It works mainly on increased satiety and delay gastric emptying. Usually, we start an initial dose of 0.5 milligrams subcutaneous once per week for 4 weeks. Then we escalate the dose until we reach the maximum, which is 2.4 milligram. And the most common side effect, as we know, GI symptoms in form of nausea, vomiting, diarrhea, or constipation. In October 2022, the American Gastroenterological Association recommend or suggest the use of semaglutide 2.4 for any obese patient with related complication, and they prioritize the semaglutide over other FDA-approved medications for long-term treatment of obesity for most patients. And now we have liraglutide, is the same group, but the difference between the liraglutide and semaglutide that liraglutide is injected daily. We start usually with 0.6 milligram for 1 week, then we escalate the dose till we reach the maximum, which is 3 milligram subcutaneous injection once daily. And here we have the combined medication, phentermine and topiramate. Phentermine is sympathomimetics, and the topiramate is antiepileptic. They work mainly centrally on the brain by resulting in reducing the appetite and decreased food consumption. But the most common side effect is dizziness, insomnia, and dry mouth. Here we have naltrexone and papropion. Naltrexone is opioid antagonist, and the papropion is an antidepressant. But as well, they have a side effect like dry mouth, dizziness, and the mechanism of action centrally on the brain by decreasing appetite and enhance and decrease food consumption. Here we have orlistat. Orlistat, it is a lipase inhibitor medication. That means it prevents the fat reabsorption from the intestine. So the GI side effect will be in form of oily stool, fecal incontinence, flatus with discharge. And the American Gastroenterology Association, they recommend against the use of orlistat in any patient who are obese and having a weight-related complications. They suggest against the use of orlistat, but they suggest using of semaglutides, as I mentioned before. And they advise for any patients using orlistat to take multivitamins daily and should be taken 2 hours apart from the orlistat. Let's have a case study example for this anti-obesity medications in better view. This is Rachel. She is 34 years old with a BMI of 33.5 milligram, presented complaining of unpredictable and infrequent menses plus hirsutism about 3 years ago. She had inconclusive diagnosis with polycystic ovarian syndrome, has been previously investigated, and she was not really sure about where it's been officially diagnosed with polycystic ovarian syndrome. But now she's been struggling with her weight for some time. So she now reached the heaviest weights as adult 95 kilogram. She tried numerous previous attempts for losing weight and tried medication in the past with Phentermine, but and she has she works as a waitress in a restaurant. She have a late night shift and the stress at work. She has a family history of diabetes, type 2 diabetes, non-alcoholic fatty liver disease in her mother, and gestational diabetes in her sister. So when we assess Rachel for her weight, we have to use other predictive tools beyond the BMI. We have to assess the waist circumference and waist to hip ratio. As we know, waist circumferences gives more information about whether fat distributed more visceral obesity, which is higher risk of metabolic syndrome. And we have to assess the comorbidities. Here in our case, we have to consider regarding insulin resistance, the diabetic status, and the polycystic ovarian syndrome. Okay, what's happened to Rachel over time? Rachel actually first started to gaining weight after she finished school and went to college and got her first job. Unfortunately, then started to develop this problem with her period. And that was really useful, pointing out to Rachel that maybe her period became irregular was actually related to her weight gain. So she did engage in a commercial weight loss program and she did well. And you can see she did respond for the commercial programs. And she lost weight, but unfortunately, because of her job and the commitment, she could not attend the follow-up sessions and stopped being engaged. Then the weight regain. After that, she was prescribed Phentermine and was successful for her. She managed to lose about 5% of her body weight, but she developed intolerable side effects like headache, dry mouth, and unfortunately she stopped and again regained her maximum weight. She reached to 95 kilograms. Okay, talking about targeting therapy for Rachel on how to choose the pharmacotherapy for this patient, this is a Canadian guidelines in attempts of choosing a pharmacotherapy. It is quite helpful because it's really thinking about complications of obesity when choosing therapy. This patient is having insulin resistance in form of polycystic ovarian syndrome. She is having family history of gestational diabetes and type 2 diabetes. So GLP-1 agonist would be very helpful for her and would be the first choice. So we recommend for her to start on liraglutide gradually until we reach the maximum dose which is 3 milligram subcutaneous injection daily. But unfortunately, she developed a GI side effect. So how we could deal with the patient with a GI side effect when initiating GLP-1 agonist? We have these guidelines we can follow, 3 E's principles. We have to educate patient before treatment, and we have to escalate the dose and use effective management for GI side effect during the treatment. This is a clinical new guidelines or recommendations to how to manage the gastrointestinal side effect in patients treated with GLP-1 receptor agonist. Practical guide to follow. As I mentioned before, we have the 3 steps. Number 1, we have to start with patient education. Patients have to learn that although GI side effect may occur, these will be transient and of mild or moderate severity in the majority of cases. So we have to advise the following a specific dietary recommendations to relieve their symptoms. For example, in eating habits, we advise to eat slowly, eat only if he is hungry, smaller portion, frequent meals, and not lying down after the meal, not using the straw, and no meals near bedtime, and not to be active immediately after the meal. For the food composition, it's recommended to be low-fat diet, boiled, clear drinks, and water-rich food, and to avoid any sweet dressing, spicy, or canned food. And for the lifestyle, advice for fresh air, light exercise, and food diary to identify what works better for her. And if they have nausea, we advise to eat crackers, apples, or mince just 30 minutes after the GLP-1 receptor agonist, and to avoid strong smell. And if they have vomiting, we advise for rehydration and to eat more frequent meals in smaller amounts. And if they develop diarrhea, we advise for rehydration and to limit the consumption of fiber for food rich of fibers, and not to have a diarrhea production. And if they have constipation, to have enough fiber in diet, having a well hydration and healthy balanced food. And in case of severe symptoms, we advise not to drink water during the meals. We advise to drink water either 30 to 60 minutes before or after the meals. Then if the symptoms are severe enough, they have to seek for medical advice. As a healthcare provider, we could modify the planned schedule by choosing one of the following points. We could extend the current phase of the dose for 2 to 4 more weeks before moving forward to the next dose. Or we could suspend the medication temporarily, and we could, if the GI symptom appears just after escalation, we could go back to the prior dose for a few days, then increase the dose gradually. But if the problem persists, we should consider setting up as a maintenance therapy the dose lower than the maximum one. As well, we could use some medications if the GI symptoms persist beyond the normal in time and severity. We could use additional measures. We could use antiemetics, for example, for nausea and vomiting, like domperidone, and we could use antidiarrheal like loperamide, and we could consider reducing the dose of metformin when needed if patient develop diarrhea, and if they have constipation, we could use laxatives. But be aware that if the drugs needed to medicate nausea and vomiting for over a month, no, we have then to reduce the dose of GLP-1 receptor is recommended. Okay, back to our case, to Rachel, when she gradually followed the strict dietary recommendations, she eventually can tolerate the side effect, and she was able to continue in it, and she actually did lose about 8% of her body weight, and her periods start to come back a bit more regular. Okay, so we have some benefits for GLP-1 receptor agonists beyond weight loss. It improves menstrual health, it reduces hunger and increases satiety. make patient more active than before and better quality of life. And the effect of semaglutide on the glycemic status, this is a trials of 2 years exposure to semaglutide. Over the left, you can see a group of semaglutide compared to the placebo. The green section, those with the normal glycemia, and you can see 50% had pre-diabetic. And now you can see the semaglutide over 2 years can convert a lot of these pre-diabetic patients to normal glycemia compared to diet and lifestyle, was a greater number still retain the pre-diabetic status. And unfortunately, small percentage go on to develop type 2 diabetes. And the key of this lecture to note that obesity is a chronic disease. So when we stop the medication, people regain. As you see in this trial, step 1 extension trial, the blue line, those participants who were given semaglutide, and you can see the weight loss in 68 weeks. Then we follow certain numbers of participants for next year without the medications. And you can see the gradual regaining of the weight. And when we look to step 5, when we continue the medication for 2 years, you can see the sustaining of that degree of weight loss. So chronic long-term management for obesity is the key, and it is important to be considered to maintain weight loss. What's new in bariatric and metabolic surgery? Okay, as we know, the indications for metabolic and bariatric surgery, depending on the American College Cardiology and the American Heart Association and the American Association for Clinical Endocrinology, they urge advice for bariatric surgery for individuals with a BMI of at least 40 kilograms per square meter or a BMI of at least 35 kilograms per square meter with weight-related complications. And in 2019, the American Association of Clinical Endocrinology added that for patients with a BMI of at least 30 kilograms per square meter and type 2 diabetes, whose blood glucose could not be controlled by lifestyle and medications. But in 2022, the American Society for Metabolic and Bariatric Surgery have updated their indications for bariatric surgeries. So they recommended bariatric surgery for individuals with a BMI of 35, regardless of a presence, absence, or severity of comorbidities. And they recommended in patients with type 2 diabetes and BMI 30 kilograms per square meter. And they should be considered in individuals with patients with BMI of 30 to 34.9 who do not achieve the durable weight loss in non-surgical methods. Okay, what are the effectiveness of metabolic and bariatric surgeries? Studies have documented that diabetes remission after 1 to 5 years in 30 to 63% of patients who did the Roux-en-Y gastric bypass. And at least 35 to 50% of patients who initially achieve remission of diabetes eventually may experience recurrence. But overall, the median disease-free period was about 8 years. So how we could predict the successful of the surgery? We have some predictors. Assess if we are having a successful bariatric surgery. If we have a short duration of diabetes, less than 8 years, and if we have lesser severity of diabetes, and if there is a greater baseline visceral fat, are also may predict improved post-operative outcomes, especially among Asian American people with type 2 diabetes. Okay, what are the FDA approved procedure for weight loss? We have laparoscopic gastric banding, which is a silicone-filled band that wrap around the upper part of the stomach, so reduce the consumption of food. The favorable aspect that there is no anatomic alteration, removable and adjustable, but there's high risk for erosion and prolapse. We have a sleeve gastrectomy. The target weight loss is from 25 to 30%, easy to perform. no anastomosis, but if leakage happens, it's very difficult to be managed. And about 20-30% of patients, we may develop GERD. For Roux-en-Y gastric bypass, the target is 30 to 35% weight loss, and is one of the strong metabolic effect, has a strong metabolic effect, and effective for GERD. But the weight regain risk is very high, and it may increase risk of marginal ulcer and internal hernia. And we have pancreatic diversion with duodenal switch. The target is 35 to 35%. It has a very strong metabolic effect, and it's only advised and effective for patients with a very high BMI. And it could be used as a second stage after sleeve gastrectomy. We can use it. But it has high risk of GERD, and there is a protein calorie malnutrition and duodenal dissection. Last one, we have intragastric balloon. The target weight loss is minimum only 10 to 12%. It's temporary. It's a silicone filled normal saline balloon inserted inside the stomach for only 6 months, about 6 months. It have temporarily may have nausea and vomiting. In conclusion, making the patient comfortable is the key step. So we have to show empathy for patients, and precise diagnosis and assessment is crucial in the management of obesity. Understanding the patient's expectation and decide on a treatment goals. And we have to know that obesity is a chronic disease and needs long-term care. Thank you.
Thank you very much, Dr. Saad. We have some questions from the audience. The
Yes,
first
sure.
question, what about using Mounjaro injections to decrease weight? Is it similar to surgical procedures?
Yeah, it's highly, it shows high reduction in weight loss. And it could, and we have to use all pharmacological medication for anti-obesity medication before surgical treatment.
That's great. So the second question, regarding the balloon as a choice of surgical procedures to decrease weight, is it safe for long durations?
No, it's not safe for long duration, and it has a side effect like erosions for the stomach, and it's temporary, only for 6 months.
Nice. And the third question, what is the appropriate choice to decrease weight in pediatric age group?
In pediatric age group, there is some new recommendations that we could use the GLP-1 receptor agonist among adolescents. There's a new articles for semaglutide could be used in among adolescents. And we have other options as well, could be assessed by pediatrician and endocrinologist.
Okay, thank you very much, Dr. Suad. That's all for the questions. We will take a 10-minute break right now, so grab some coffee if you would like. Thank you.
Thank you.
Dear audience, we will be back at 10:40. Okay? Thank you very much. Assalamu alaikum. Welcome back, everyone. Our third speaker for today is Dr. Wafa Al-Sheikh, Consultant Family Medicine, Ministry of Health, and Trainer in Family Medicine Academy. She will be presenting common psychiatric disorders in general practice. So welcome, Dr. Wafa. Happy to have you here today.
Hello, Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Hello.
Yes, it's very clear, Doctora. You can start.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuhu. Let me introduce myself. My name is Dr. Wafa Sheikh, Consultant Family Medicine. First of all, I would like to thank Dr. Arij and the whole team for managing this wonderful occasion and allow me a chance to give and to participate and share my clinical experience at this platform. I hope all you people will get benefit from this session. All are the real cases that I have been encountered during my clinical practice. We will discuss the common cases of mental health disorder or the psychiatric disorder that is comprises of depression, anxiety among the different age group. And I will let you know that how you will use the psychometric tools, assessment of the depression and anxiety, and the use of the 5-step approach by the WHO, how to diagnose the depression. And we will deal some clinical comorbidities and the confusion during the pregnancy, and then OCP we can use, or chronic migraine. So I hope that it will be a beneficial session for you. My first case, I remember the similar boy, he came to my clinic 2 to 3 years ago, Fawaz, and he was a school boy. He came with a school bag. He was very anxious. He was very irritable. Initially, he came to my room and he was, holding his leg, and he was having no eye-to-eye contact. And he complained that, and was having something very interesting. He was holding a mobile in his hand, and he was attending the lecture of the school. He was a school, I think, grade 10 student, and he was saying, I am unable to concentrate on my study. I am not feeling well. I am hopeless, helpless, and my grades are decreasing, and I cannot enjoy my life, and I need help. So this is the usual presentation of the students and the adolescent age group. Usually, if they might come, I have about the 14% of the students, they do come with this age group. And this is the main complaint. They do come that I cannot pay on my study attention, and they want to absence from the school, and they're reluctant to go to the school because their marks are decreasing and they are under pressure from the school and from the home. So about the Faisal, you will have some more details that he's the youngest child of the family, and he was having all the time, he grown up in an environment, there was always the parental conflict. And according to his, he says, because he came without his parent, he said they're very old and they have so many chronic illness, and might they have the psychiatric complication with them, and they didn't understand his emotions and the problems. He has some brother and sisters, but they're busy in their life, so nobody concerned about him. So for all these issues, what he did, all the time he's doing the smoking, but he is not getting relief from this act. So these are the risk factors. If you see that he's a young boy, adolescent age group 15, feeling lack of allergy, he is hopeless, helpless, he is complaining of insomnia, anhedonia, he doesn't play his favorite game, football, and he's grew up in a, this is another risk factor, that the environmental risk factors, that the parental conflict, fighting all the time, the family, and he's older under the stress, and he started smoking. Something very important in the assessment part, that either history of the drug abuse, or that is very common nowadays, or something very crucial, or ask about the suicidal ideation. So the Faisal, he didn't accept the smoking. He doesn't have any history of the substance abuse, and he never think about the suicide. So please, this is actually the underestimated and underdiagnosed and undertreated adolescent age group. People, they cannot share their feeling and the emotion and behavior with their parent at the school. So they present with the abnormal behavior. And either their performance may be decreased, or they have bad relationships with the family and the friends, and either they start to use the substance abuse. Nowadays, I have seen the last month 3 cases, younger age group, they are having the history of the smoking, even the alcohol and hashish, and either they do present with the anxiety or the panic attack or the social phobia. So these are the risk factors. What are the presenting complaints? They do come. It is very common. If WHO has been said that 1 in 6 in the adolescent age group, they do have the depression, and this is the 16% of the burden of the global health of the adolescent age group, and 50% about the age of 14, they are still undetected and untreated. And depression is now one of the leading cause of the disability and the illness of the adolescents, and suicide is the 4th leading cause of among this age group. In Saudi Arabia, the study was done by the Nadal Yousfi, and they found that the moderately severe depression was found among the recent age group was 32%. Whereas in Abha, they found in the school girls, they found the depression 41%, anxiety 66%, and the stress was 55%. As compared to the male adolescent boy, they have the depression 38%, whereas the anxiety 48%, and the stress is 35%. Here you can see the studies, they have been found that the anxiety is much more higher than the depression, and this is true figures. So what are the factors that might develop the depression in the adult age group? The social media, of course, this is one of the very dangerous and the critical cutting the part for the development, because they have disparity in their life, their reality, their perceptions, their future plannings, and then if there's one of the strongest factor of the depression is the family history. You need to ask always about whether their parent, their sibling, they have family history. So it is a strong clue. Then the family conflict. If the patient, they have the history of the broken family, they have conflict all the time. So they might have the problem with the family and the friends. Sometimes they encounter with the bullying. This is also very common. So many girls and the boys, they are coming to my clinic and they are suffering from the bullying, and they develop the depression, anxiety, and the panic attack. Abuse should be ruled out in all the cases, because children, they are unable to share their feeling and emotion unless they are very confident with the physician. So the abuse, all the type of the abuse, not only the physical, there is a sexual abuse prevalence is very high. So be careful if they're coming with depression, especially the girls. You need to ask about any type of the abuse. This is one of the, again, from the major risk factors. Then the children, because they are young, so they cannot cope. They don't have the coping skills. If they encounter with some problem, they don't know how to deal with them. And again, the past history of the depression, something very important in the children and the adolescent age group. History of any psychiatric illness like anxiety, social phobia, learning disabilities, if they are having a problem in their studies due to the ADHD or the autism or the conduct disorder, opposition deficit disorder, these are all the risk factors that might develop in the future depression. Then if there's a history of the brain injury or the low birth weight or any associated chronic medical illness. So in the history, these points are very important, crucial, because the depression or the psychiatric or the mental illness, these are all are the diagnosis of exclusion. So we have to rule out all the medical and the other chronic illness, and we have to need a very good approach and the good communication skills to assist this patient. So the diagnostic criteria for the depression according to DSM-5 in the children, as everybody know, I think by this time, that 5 or more of the symptoms should be present every day for at least 2 weeks. So we can do this in a daily routine by asking the PHQ-2, the true screening question, loss of mood and the loss of interest for the duration of 2 weeks. Then furthermore, if one of the question is positive, like if the child is saying that I have a loss of interest and loss of mood, or either they are coming with the irritable mood, so we have to continue the rest of the criteria. Like for the PHQ-9, or it is similar to the DSM criteria 5, we need to ask about the change in the appetite, sleep disturbance, psychomotor agitation. They are all the time restless. They feel fatigue, loss of energy, and feeling of the worthless. hopeless, helpless, like the Faisal. He has almost more than 5 criteria in our case: decreased concentration, but he doesn't have the source of thyroid. But you need to be asked. That is very important and crucial, because this is a medical emergency in the psychiatry. You need to refer the patient immediately to the hospital. Okay, so Faisal is comprises almost all more than the 5 criteria, more than 2 weeks. So his history of the 6 months. So we can diagnose him as a depression, and then depression again. You have to pay attention on the history. You need to rule out any associated medical comorbidities. For example, iron deficiency anemia, hypothyroidism, vitamin D deficiency. These are very common comorbid condition, and they have the similar mimic the presentation of the depression. So you have to ask the basic investigation to rule out the medical cause, and then you can proceed to the psychological cause. So the psychological cause, the patient might have the psychiatric illness or the medical illness. You need to ask the family history, the drug history. There are some drug for example, the steroid, the patient has a known case of the bronchial asthma. So he might have developed the depression, the substance abuse. You need to be asked. Life stresses. This is one of the common issues and very prevalent issues nowadays. You need to be asked and assess the level of the functioning, like if they are saying they are unable to do their activities normally and they are declining their studies. And then social support by the family and the friends and the parents. And one of the clue, the mini mental status examination we are going to do, but we are not doing actually just like the physical examination. This is the observation during the medical or the psychological interview. You find the findings. We will see in our case. So if you see the Faisal, his blood pressure was normal, height and build was okay, and but on appearance, this is the mini mental status examination. You have to look forward for the appearance. So he was looking anxious, angry, irritable. He was sitting at the table all the time. He was moving his head. He was no eye-to-eye contact with me, but he was looking a little bit sad and anxious. His tone was very angry, but he was having insight. What do you mean by the insight? Insight means that he has awareness that he is having some problem and he want to solve this problem. Either the problem you need to detect, but the insight means the patient is awareness of the disease, that he know that he's sick, as compared to the patient if they're coming with the like schizophrenia or the mania or the bipolar disorder. They don't have the insight. They say, we are not sick and I don't need to get any treatment and any help. So this is the insight. So he had the insight, and we need to ask always in the history of the hallucinations or the delusion, and he was conscious and alert. Finally, I'm using in my clinic, the PHQ-9 and the GAD-7 in Arabic version. When at the initial of the interview, I give to the Faisal, I was thinking that he is depressed, but I found the most common comorbidity. This is usually happen that the depression and the mental disorder, they are associated with the comorbid conditions. So he was having the severe depression and the severe anxiety. As you can see, this is comprises the criteria of the DSM-5 and the GAD-7 for the diagnostic criteria for the anxiety. So we diagnose the Faisal with the severe depression and anxiety. So what is the plan of management? The plan of management usually, you should know that all the mental health disorder, whatever the depression, anxiety, schizophrenia, substance abuse, we are giving the combination therapy. What do you mean by the combination therapy? Combination therapy means we are starting with the psychotherapy along with the pharmacotherapy. And here you can see the largest study was done, the treatment of the adolescent depression study, TADS study. It found that the combination therapy is superior as compared to the therapy alone because it improves the symptoms greater, okay, at the initiation of the therapy, and rapid improvement. So among the psychotherapy, if somebody will ask you that what is the best psychotherapy, so in the adolescent age group, the interpersonal therapy from all the studies or the TED study found, or the GLAD-PC guideline for the adolescent depression, they found that the interpersonal therapy for the adolescent is the treatment of choice as cognitive behavioral therapy. So along with the cognitive behavioral therapy, we are going to start the pharmacotherapy. And what is the pharmacotherapy of choice? Is the fluoxetine. All the studies has been found that you cannot challenge the benefit of the fluoxetine. Fluoxetine is a SSRI. This is a treatment of choice. This is less sedative as compared to the rest of the drug. Here you can see the arrow, the citalopram, escitalopram, sertraline, fluoxamine, and the paroxetine. All these drugs are gradually increasing the sedation. So these are the fluoxetine we want to give to the students, especially in the children, so they keep them active, they can give alert, they have good concentration, so they can study well, and they keep them active. So our plan of management with the agreement of the Faisal, I informed that we are going to start with the CBT and the pharmacotherapy, and our plan for the cognitive behavioral therapy or the psychotherapy, refer the psychiatric hospital in the MMCH. There is a CBT clinics are available in the Mustashfa Amal, so we are referring the patient for this reason, with the severe, especially moderately severe and the severe depression. And at the same time, my plan was to start the fluoxetine. Ultimately, this is the most common question once you are in a clinic, because you know the antidepressant and the antipsychotics treatment, this is a dilemma and this is a stigma. So ultimately the question, there is a side effect, for how long I will take this medication, and when I will improve and when I will stop. So the patient education from the up to date, this is very important. This is, I think, the most cornerstone part of the management. If you do not educate the patient, I think you will lose your patient, and maybe he can stop his medication at any time. So you have to inform the patient the benefit and the risk, about the timing and the dosing, the length of the duration, and any potential interaction. If you don't make agreement with the patient education, I think you will fail in the treatment of the psychotherapy and the pharmacotherapy. How do we start the treatment? Usually treatment, we will start for the first 2 weeks with the low dose, and treatment should be continued for 2 to 6 weeks, because this is the time when the treatment start to work, SSRIs. For the adolescent age group, there's a difference from the adult, that you need to follow weekly for the 1 month initial visits, and then bi-weekly every 15 days in the next month, and then every month for the 3 months. Once the patient will become stable, then you continue the treatment for the maintenance therapy for 6 to 12 months. And the maintenance therapy depend on the situation, and the treatment is individualization according to the patient situation. But usually the treatment full course is 6 to 12 months or 1 year. So we start the treatment, we reassure the patient, clarify the Faisal, refer for the CBT, we start the pharmacotherapy. Usually we start the half of the dose for the first 10 days or the first week. So he will have the less side effect. And if he has any type of the side effect or the symptoms, we need to see after a week. So first week we are giving the 10 milligram fluoxetine, and the next week we are increasing the dose 20 milligram. I have added here the lorazepam if the patient has severe anxiety and the severe depression. So you need to stabilize the patient and reduces the side effect of the fluoxetine, as the fluoxetine is causing the agitation and the irritability, so it might aggravate the anxiety. So according to the guidelines, you can add the lorazepam if it is available in your hospital, 2 milligram OD for 2 weeks. But here you have to notify the patient that you have to stop this medication after 2 weeks, and we will continue with the fluoxetine SSRI, because it might cause the addiction. As you know, it is the drug dependence drug. So after weekly, we will follow for the 1 month, and then bi-weekly for the 2 months, and then we will follow the patient every 1 to 3 months. Here, I would like to add one point, that why we want to ask the patient to see every 1 to 2 weeks to assess the response of the treatment. What do you mean by the response? It means that he is improving and symptoms are reducing, 80% or the 50%. Remission means the patient will totally cure and he will not have any sign of symptoms, and his PHQ-9 will be 0 at that time. So Faisal was very happy, he's feeling better, and suddenly I lose his follow-up, and this is usually the happen. The 70% of the adolescent age group, once they become good, and so they want to trial by themselves, then they stop the medication, and after a month, exactly the same, the Faisal came and he say, I have again the signs and symptoms of the depression. It is less severe, but I am suffering. So patient education and agreement is very important. I take again an agreement, but you know, this type of the age group, they are very arrogant and aggressive, and they are very impulsive. So very difficult to take the confidence and the adjustment of the dose. But you ask frequently, monthly, to call them and to continue the follow-up and to give them the benefit of the improvement of the treatment. So now, till now, Faisal was taking continuously the medication every 2 months. He was following regular follow-up, and now is our plan after 2 years to stop his medication. So this was the first case. So here you can see if the patient has stop his medication or have a relapse once. So the treatment duration will be the 2 year. If he has a 2 times stop his medication, twice relapse and history of the 2 major depressive disorder, then he has to take the medication for the 3 year. And if he stop the medication 3 times, so the treatment might be lifelong. This is the first case we have done with the depression and anxiety in the adolescent age group. In summary, they do present with the restless, irritable, and decrease, the concentration, decrease the marks, and you can assess them easily with the PHQ-9 and the GATE-7. And the treatment of choice is the pharmacotherapy and the psychotherapy, the CBT referral for the hospital, and you can start the fluoxetine, the 20 milligram, 10 milligram initially for the first week, and then 20 milligram for the so on, and continue follow up every weekly in the first month, bi-weekly for the second month, and every 1 to 3 months till the patient becomes stable. Treatment duration is 6 to 9 months. I hope this case we have finished successfully. This is my second case. Is Amina. She is referred to me in my clinic from the general physician, and she said this patient has unresolving chronic headache, and she is not improving from any type of the analgesics. When I took a detailed history, regardless of the patient referral, always just be non-judgmental and take a detailed history from yourself. So when I take the detailed history, I found that she has a throbbing pain, nausea, vomiting lasting for 2 to 3 days, and an episode lasting for 3 to 4 times in a month. And again, she's saying that she has a difficulty in the sleep, but otherwise she doesn't have any chronic illness. Apart from she's taking only the analgesics, paracetamol, sometimes brufen, but she's not getting cured. Along with this, because she's a reproductive age group female, so she is saying that I am on the OCP since 4 years. At this time, when we start to check her blood pressure from the baseline, it was 130 and 90. So our plan was to stop her OCP and change the alternative method of the contraception because it might aggravate the migraine with aura, and it can increase the risk of the depression and hypertension. Patient came after 2 weeks. Her blood pressure was this time improved and she was happy, but still she is complaining of headache. So here you have to suspect some another thing, okay? So here I would like to introduce, this is very useful tool, 5-step protocol for providing the mental health care and the primary health care. WHO, it is implemented by our great consultant and the physician, Dr. Abdullah Al-Khasami, and it is implemented now, I think, almost all of the Asian countries and abroad. So here are the 5 steps. I think this is not very clear, but I have been written here one by one. The step 1 is the suspect. When you suspect the patient, when the patient has history of the frequency of the visits or the chronic pain. So it means there's a hidden agenda. If the patient is coming again and again, and he's saying, I'm not improving, and he's coming all the time that I have low back pain or headache or sometimes, suspect this patient. He has some hidden agenda. Second, if there's a suspicion, the step 2, you have to follow for the screen for the depression and anxiety. How do you do screen? Again, the PHQ-2, loss of the mood and the loss of the interest for the depression and for the anxiety. Are you have any worries for the last 2 weeks? If the patient say yes, it means the step 2 screening is positive for this patient. So here we will go assess here in this step 2, either the patient has any type of the stress. Okay, what are the type of the stress? Might he has a sleep disturbance, or might he has declined his performance, or might they have the problem in the relationships? So here you can see I have applied my patient's problem, that when I find that he has, she was positive for the depression and anxiety, she was having complaining of the sleep disturbance, she was having unreplenished sleep all the time, she is not working as like before, and so her performance is moderately severe, and she has conflict all the time with his husband and the children. Even she was abusing her children because she was under severe stress. So we will, if she has the stresses, multiple stresses, you have seen, go back the previous, if she has sleep disturbance, she has a performance difficulty, she has the daily conflict or the difficult in the problem in the relationships. If you say yes, you have to proceed to the step 3. The step 3, you have to ask about the suicidal ideation, about the history of the psychotic illness or the substance abuse. In our patient, I didn't find anything, but at this stage, if you find the patient has a history of the hallucination, delusion, psychosis, substance abuse, immediately stop here, refer the patient to the psychiatric hospital. Your job has been finished. But if the patient doesn't have anything, like no history of the suicidal ideation, she doesn't have any hallucination or the delusion, no history of the substance abuse, alcohol or hashish or any type, or no history of the high or low mood like bipolar disorder, so we will continue for the step 4. Step 4, we will find that she has a low mood, loss of interest and worries. So we'll continue to complete our DSM-5 criteria, depression and anxiety model. So here I found that she has the PHQ-916. It reveals that she has a moderately severe depression along with chronic migraine headache. So diagnosis of our case of Salma, that she has moderately severe depression with the chronic headache. How do you manage? Yes, of course. 2 things you should know, that the migraine, according to the American Migraine Foundation 2018, they found there is a strong relationship between the depression and anxiety and the migraine. Migraine is 5 times more common to develop the depression as without migraine. And here's something very important, then 25% of the patient migraine, they have depression, and 50% they have anxiety. Okay, so you need to do a screen whenever the patient is coming to your clinic with that migraine. You always please ask the 2 questions for the depression and anxiety to rule out the mental disorder. So what are the treatment of choice? Here you can see we are not going for the SSRI typical like escitalopram or something. We are coming here for the SNRI, serotonin norepinephrine reuptake inhibitors, vilnafexine. Vilnafexine is the only drug of choice to be given with the depression and chronic migraine. Here, something very important I want to tell you, that if the patient has history of migraine, before starting any SSRI, you need to ask either patient is on the sumatriptan. Why? This is a crucial again. If the patient is on the sumatriptan, he didn't ask, and you start the SSRI, there'll be a great drug-drug interaction. Patient will have maybe acute coronary syndrome. So patient will be in the trouble and there will be no more safety. So be caution before starting the patient have the depression with the migraine. Ask if she is on, you need to stop the sumatriptan, or either you need to take some another medication like the amitriptyline, safer medication for the migraine headache. So I hope my message is clear that for the migraine headache, if the patient has on the sumatriptan, SSRI should not be prescribed. This is contraindicated. Okay. So what is the drug of choice with the migraine headache? Either SNRI, vilnafexine, or the amitriptyline is a drug of choice. We can give for the prophylactic doses for the lower, for the duration. So the step 5, we start always start. I forget to mention this point, that always we go from the diet and exercise, because they are from the BMJ and the up to date. All they do recommend the patient, if they have depression and the anxiety, you have to say that you have to stay the healthy lifestyle and the exercise. It improves. Then cognitive behavioral therapy is the second step, and we can give the type of the supportive and the narrative therapy. And the pharmacotherapy, we will start the vilnafexine, again half of the dose. Please remember, we are not starting the full dose to prevent the side effect, or contrary. So we are starting the half of the dose of the vilnafexine, 37.5 milligram first week, and then in the second week we will start the 75 milligram. Follow up the patient after 2 weeks to check if she doesn't have any side effect, or to see the improvement of the symptoms. After 4 weeks, when she came, she was still sad, but her PHQ was 9. So our plan is to increase the dose of the vilnafexine 150 milligram OD for 4 weeks. Next month she came, she was happy. She doesn't have any complaint of headache. Her PHQ-9 was 0. It was a remission period after 2 to 3 months. As I said earlier, response to reduce the sign and symptoms, and the remission means the patient is totally cured. So our plan is now, after 3 months of the remission, to continue the treatment for 6 to 9 months for the maintenance therapy. So in this case, what in summary, what we have learned, that if the patient is coming with the depression and the migraine should not be start the SSRI. This is the first thing. And second thing, we can apply if the patient has chronic headache and the frequency of the visit, we can suspect the patient, and then we have to screen the patient for the depression and anxiety, and we have to rule out any stress. And if there is any history of the hallucination delusion, we will refer the patient for the psychiatric hospital. Step 4, we have complete our criteria for the diagnostic purpose, and finally we have to treat the patient. So the venlafaxine is a drug of choice for the patient with the chronic migraine. And I hope you learned from this case. And now I will proceed for the case 3. Case 3 is about elderly lady. She came with the depression. You will learn today the variety of the cases with the difficult psychometric tool. Here, Saida, she's came to me, and she is coming so many times, but every time she was having the new complaint and requesting the investigation. Please do for me that I have a headache. Sometimes she's saying I have a low back pain. So you need to know that why she's coming again and again. Again, hidden agenda. Frequency of the patient to the primary health care. You need to assist patient very well. Again, this visit, she was very anxious, no eye to eye contact, and she complained only the sleep disturbance. Otherwise, she said, I am okay, but she is alone. Her husband has been died few years ago. And she has one daughter, but she's not living with her for the study purpose. She was in another city in Riyadh. Khala Saida, she was also having the hypothyroidism, gout, and the osteoarthritis. She's on treatment and she was stable. So here we can see that patient has frequency of the visit, and she has a sleep disturbance. So she was in a stress. So suspect might she has depression. So here I would like to introduce something new, psychometric scale, depression genetic scale. You see the genetic age group, when I use with them the PHQ-9, it is not worthy, and it was not working with them. But if you want to become a little bit crucial, you can go for the depression genetic scale, and this highly sensitive and highly specific. Only the 5 questions. This is the modified genetic depression genetic scale, and beneficial and short, and it will not time consuming, either the positive or the negative. So when I ask Khala Saida that are you basically satisfied with your life, she say yes, because usually they are saying yes, alhamdulillah, they are saying like this. So when I ask her, did you often get bored, she say yes. You are helpless, she say yes. And she is staying at home, she is burdened for the others, she say yes. So score was 4, and DPS was positive for Khala Saida. Easy and simple. So 45% of the patient you can diagnose with the depression in the genetic age group by the Al-Shamari, and the depression, regardless of its severity, it found 63% among the genetic age group. Mild and the moderate depression was reported 47%, and 40% of the patient, they have the severe depression at the younger age group. This is another study done by the Ghaznavi and the Hassan Al-Musa. So you can see the prevalence is high among the genetic age group. What are the factors that might lead to the depression in the genetic age group? You know, all the comorbid illness, whatever. If it is the depression, and it either this is the diabetes and hypertension, the cardiovascular disease, cerebrovascular disease, the multiple drug interactions, and female gender itself, she's widow and she's divorced. If there's a lack of support and they are socially disadvantaged, and they have other significant illness. Precipitating factor, if the loss of the spouse, if they are alone, they are in nursing home, usually abroad, you know, they are nursing home, and they are having separation, financial crisis, health decline, the marital problems. So recently, the bereavement patient should be screened for the late life depression. Once the patient, they are coming that he has lost his spouse, either male or the female, you should screen for the depression. So what you will find, you see there is a difference in the presenting features. Elderly at the age of 60 and 65, they do not present like in the adolescent age group. They were very irritable, impulsive behavior, anxious. The adult, they are present differently with their problems of the home and the work and the social life. Elderly, they do present with the decreased cognition. They have marked diminution in the interest. They are saying, I don't want to do anything. I cannot enjoy my life. And they are coming with the dementia. So here you need to do the Mini-Cox scale. I did for the this patient, Saida. And apart from this, you need to ask about the loss of weight, loss of appetite. This is one of the strong clue for the elderly. They are losing their weight. Either they will have, of course, the physical illness, chronic pain, or the substance abuse, or the opioids. They do complain the fatigue, energy, lack of energy, psychomotor retardation, and feeling of the worthless, and they do have the suicidal ideation, especially the males. So you need to ask about the suicidal ideation, especially in the late life depression. Again, the detailed history, I told you this is a clue because we don't have any test or any thing to confirmation our psychiatric illness. So the history is the main stay of the diagnosis. So you need to ask in a detail about any psychological, another psychological illness, physical illness, or any suicidal risk. If the patient has any family history, the drug history, life stressors, and like the family situations, and you have to go for the mini mental status examination. And sometimes you need to take the history, the collateral history from their, from their daughter. Sometimes if they are coming with them, for the children, you need to ask from the parents, from the teachers. That is quite helpful. The management of the late life depression, we are treating them again the combination therapy. So by this end of the lecture, I mean you should be confidently treat the depression, all the type, whatever, or the age group, with the pharmacotherapy and the psychotherapy for both. So the milder depression can be treated with the psychotherapy, but for the moderately severe depression or the severe depression, we have to add the psychotherapy. Again, I want to add here something very important point. If the patient has milder depression and they are coming with the insomnia, only the insomnia, you need to start the pharmacotherapy. It means she is suffering from the severe depression. So Saida, she has help-seeking behavior. She has frequency of the visits. She has multiple predisposing factors. She has sleep disturbance. Geriatric GDBS score is 4. I did with her with the Mini-Cox scale. I asked her to draw the clock and give her 3 words, and it was negative for him. So this is also very important. Please do for it, because maybe this time patient, the initial stage of the Alzheimer's disease or the dementia. So we have ruled out here the dementia, the cognition, but the depression in the elderly, they do present with the decreased cognitive level. So our patient, she has moderate depression. So the plan of management, again, SSRI, along with the psychotherapy, the treatment of choice. Usually in our primary healthcare, citalopram is available. Citalopram is also safe. This is having the less drugs interaction and the side effect. So you can go very easily, because the paroxetine and the sertraline, it is better to give in the adult age group, because these are strong sedative and they are coming with the like severe depression with anxiety and the insomnia. For elderly, it is very important you give the lesser side effect, less sedative, because it increases the chance of fall. You need to be careful and might drug interaction. Sometimes if the patient didn't improve, we can go for the second drugs like SNRI, bupropion, meclobamide. They are well tolerated, but in the case if the patient did not respond to the initial drug, but usually the 90% of the patient, they do go well with the citalopram and the citalopram. So again, in the elderly, you have to start low, go slow, like half of the dose. This is the rule of thumb and the gold standard to start the medication in the psychiatry. So they will not have the severe sudden symptom. I remember one case. She came, she said, I start the full dose and I have a severe side effect of the insomnia, agitation. I cannot take anymore, and she stopped immediately. So that's why start low, go slow, half of the dose, and you have to check the response. Response, I means, I told you, you can check by the symptoms or by the validated psychometric scale, GDS score, or either something to assess the prognosis and the treatment. And the remission means once the patient has fully cured. You have seen in my cases that patient was initially having scores 24, and later on after 3 months of the treatment, they are having a score 0. So it means they are improving, or either by saying, if you ask, how are you okay? They are saying, I'm totally perfect, I am happy, no need for the treatment. Even they are saying like this, there's no need to treatment, I am feeling better. So please ask the patient, stay on the treatment. Maintenance therapy is very important to avoid the relapse. So after the agreement, why I am saying, because you have to stay about 40 minutes in first session of the patient to educate them very well that you have to start the therapy gradually, then you will improve. And if there's a side effect, we will change the drug, but you have to continue after the improvement. You have to continue the maintenance therapy to avoid the relapse. And then even the stoppage of the medication, we are doing gradually within 1 to 2 months. So we start with the escitalopram 5 milligram for first 2 weeks. She came after the 2 weeks, she's feeling better, her sleep was improved. She's giving, it means she's giving good response. If she is feeling better, I am okay, it is okay, more than 50%. Then next visit, she came after 1 month, she says it's still restless, she's not up to the mark, like 100%. So I increased the dose 10 milligram. After 8 weeks, 2 months, the patient came, she was stable, she was okay, her sleep was improved, and she was very happy. So by this time, I start the maintenance therapy for 6 to 9 months. We continue her treatment. And after a year, Khala Saida, she was very happy. She's fully recovered from the depression of the antidepressant. And we stopped her medication, and we have stopped till now. She has a stopped medication, and she is feeling happy because another reason of the risk factor, her daughter, she has finished her education, she's living with her, she is no more alone. So and she is happy. Okay, so we have treated successfully this case. And my last case is the Safia. She is 40 years old, and she came with the excessive worry and anxiety, very anxious lady. But this time, her worries and anxiety was started when her close relative has been died. She was very nervous. Usually they do present. This is a presentation of the anxiety, and she was unable to concentrate. She was feeling tired all the time. She has a disturbed sleep. Of course, with the anxiety and the decreased concentration, and the deeply one cannot be sleep the whole night. And along with this, she has something very typical feature. She was saying, whenever I went to sleep at night and I put head on my bed, I have start feeling the severe palpitation and the chest pain and the dyspnea. I cannot breathe. And by the same time, she was having the gastritis, flatulence, and the abdominal pain. So here we can see that she is having the anxiety with the panic attack at that. Okay, this is a very frequent comorbid condition that usually the anxiety and the depression, they do present with the panic attack, and usually patient, they delay to seek the medical advice. They have the depression, they have the anxiety. Once they start to develop the panic attack, they seek immediately the medical advice. So, but she, in the previous history, as I asked, you need to ask either she has history of the previous medical or the psychiatric illness. She said that she was having similar history 6 years ago for the anxiety. She was treated for the SSRI. She improved. This is again clue. If the patient has been treated, you need to ask for how long, what is the type of the medication she was on, and how and what was the duration of the period she was improved. So in the secondary, this is good. If you have like this, you can start the similar medication and similar dose, so patient will get improved because there is no need to try the new medication. So otherwise, she doesn't have any chronic illness, she doesn't have any psychiatric illness, she married 3 children, she has a happy life, she has good relationship with his husband, but she's on OCP as she's a reproductive age group 40, but she still want to conceive. So she was a little bit conscious. She said, might SSRI interact with the OCP, and if she is safe for the future plan of the pregnancy. On examination, this is two concern we will deal, inshallah, in the few next slide. Examination, the vitals were stable, and on the mini mental status examination, she was anxious and or the nervous. She was moving her eyes and hands all the time. She was irritable, but memory was good, inside is good, no hallucination, no delusion. This is her GAT-7, and you find all the symptoms that she was feeling nervous, and she was at the age of the chair, and she was unable to stop her worries, and she was worrying for everything. Generalized anxiety disorder, usually the patient will be worried for everything, for present, for past, for future, even for the past, what has been happening, in the future, what will happen, and currently what is going on, for everything, for the children, for the health, for the food, for the guests, for the parties. And they cannot be relaxed, and they are hyper anxious patient. They have type A personality, and they are easily annoyed, and they are highly irritable, and they're afraid something might be happen suddenly. When I give her the GAT-7 in Arabic version, and we found that she is having the severe anxiety. Our case, she was as diagnosed with the with the severe generalized anxiety disorder with the panic attack, and she has two concerns: either the antidepressant she can take with her OCP, or it might affect on her future pregnancy. So what is the diagnostic criteria? You can see that the excessive worries and anxiety should be last for at least 6 months. Okay, so once the patient say not for 1 month and 2 months, you cannot diagnose the generalized anxiety disorder. The duration should be at least for 6 months. Then the anxiety or worries are accompanied by at least of the 3 of the following cognitive or the physical symptoms. For example, restless, feeling of the edginess, tiring easily, fatigue all the time, decreased concentration, irritable, feeling muscle tension and the soreness and difficulty in the sleep. And you can see our patient, Amina, she was having difficulty in the sleep. She was having the irritability, decreased concentration, and she's worrying all the time. So the screening question here for the worries is for the generalized anxiety disorder. Are you worried all the time? If she says yes for the last 2 weeks, okay, go proceed for the DSM-5 criteria for the generalized anxiety disorder. Here, because I told you that the 70% comorbid condition is the panic attack. Usually, when they come to the clinic, they start to have a panic attack after the anxiety development. So, how do you diagnose the panic attack? This is sudden, severe, intense feeling of the terror, usually at the night once they are sleeping. Most of the patient till now, I am working in the clinic, they are coming that at the night when they are going to sleep, there is no work with them. They have sudden onset of the attack, and it is last for the 10 minutes and then subside. The most common presentation they are coming with, and they are afraid, and they are thinking this is lethal, and they are going to the ER frequent visit. They are doing a lot of time ECG, chest pain, palpitation. And studies has been proven the chest pain, the palpitation, feeling of choking, dizziness, especially they are thinking fear of die, they are thinking they might have heart attack, angina. So once you come to you, so you will find a bundle of ECGs in their hand, and they are still concerned despite the ECGs is normal, despite the troponin I is normal, despite the echo is normal, and they are giving the duration of the 1 year or 2 year. Still they are concerned that might have the cardiac disease. So even though they will have the nausea, numbness, palpitation, sweating, and the shaking. Anxiety is one of the common comorbid condition with the panic disorder, and we have to rule out the other disorder like hyperparathyroidism or the IBS or the similar mimic presentation. We have to rule out the cardiac problem, and you can use the GAT-7 for the assessment of the severity on the further diagnosis and the treatment. And psychotherapy is the treatment of choice. Again, evidence level A from the American Family Physician, both for the generalized anxiety disorder and the panic disorder. You can choose any type of the SSRIs. This is useful, and the duration of the treatment is, of course, 12 months. And benzodiazepines is a drug of choice, again, if the patient has a severe anxiety and they are coming with the panic attack. So this is a drug of choice, benzodiazepine. If it is available, the lorazepam, tomazepam, oxazepam, you can start lower doses, 2, 5, or 10 milligram for once OD or BID according to the severity of the illness for 2 weeks. These are the drug of choices. You saw the first line of SSIs are the escitalopram, fluoxetine, fluvoxamine, paroxetine, sertraline. Either you can choose, or if the patient has any side effect, you can go to the second line or the third line. And augmentation, the benzodiazepine is worthy. If you go with the SSRI with the benzodiazepine for 2 weeks initially, patient have a very good improvement. Now her concern, can the OCP can be used with the depression? So here we have found no association with the OCP and the SSRIs, but in the younger age group females, only the one study, it was found that it can increase the score of the depression in the younger age group if they are using the OCP. Otherwise, the rest of the females beyond this age, they do not found any association with this. And another study, the fluoxetine, they are taking people, they are taking with the fluoxetine for the major depression and the OCD and the bulimia nervosa, they did not found any drug interaction with the OCP. So here we can resolve her first concern. The second, this is safe for the pregnancy. So you, if you see risk outweigh benefit. We did not find till now the studies that the drugs, it is causing the congenital malformations. Even the tricyclic or the imipramine, you can use safely in the first 3 months with the lower doses. And but it might, to be safe, increases the risk of the preterm birth, low birth weight, respiratory distress, neonatal convulsions. It might, but in my clinical practice till now, and according to the up to date, I have gone through so many studies, and I didn't find that they have any malformations, and they deliver the baby safely, healthy. And I was having the cases, the female, they were having pregnant and they were having the severe depression. They were continue on the escitalopram or the imipramine, and they run safely. Even so, I didn't find, but for be safe, what I am doing, we are lowering the dose for 3 months. This is a part of the organogenesis to avoid the concern. Up to date, it is written here, American Gynecology Association, that paroxetine is the only drug that should be avoided. But again, the new evidence has been emerged, and they are saying if the patient is stable, you can lower the dose and continue the same medication. But for the reading purpose, you should know that the paroxetine is a evidence level D, and it might cause congenital anomalies, external anomalies, cardiac anomalies. But rest of all the medication have the similar efficacy for in the pregnancy, so you can use safely in the pregnancy. So if the patient is on the medication, don't put off from the medication. It might relapse, increase the risk of the abortion, premature labor, and the premature birth. Investigation was done. Usually you have to do this investigation for all the patient with the depression, thyroid profile, vitamin D, and the iron deficiency anemia, because this means give the similar presentation of the depression. She was having normal everything, her investigation. And so our plan is again for the severe anxiety, we refer her for the CBT clinic, psychiatric hospital. At the same time, we start the patient education and start the treatment with the fluoxetine 10 milligram first week. I asked her to come after 2 weeks, and after 2 weeks when she came, she was on the 20 milligram fluoxetine, and she was improved, and her score was also improved, and she was feeling happy. And I reply her concern that we did not found any interaction between the fluoxetine and the OCP, and even during the pregnancy from the ACOG and the CDC and up to date. These are some drugs you need to know once you are treating the patient, like if the patient is came with the depression and the chronic migraine, venlafaxine is a drug of choice, and the tricyclics. If the patient is obese and she has a smoking and she has a history of the sexual dysfunction, the bupropion is only drug of choice, and there's something very unique for the bupropion, Wellbutrin. You can start 75 milligram XL OD, and then you can gradually increase to the 150 milligram BID. And you can stop anytime. This is the only antidepressant you can stop suddenly without gradually reducing the medication. Then this is also good for the sexual dysfunction. This is exam questions, you know. And the pregnancy, again, the treatment of choice is the sertraline, you should know, but you can use all the medication except the paroxetine. But I told you the new emerging evidence, but for the exam purpose, you should remember this is contraindicated, but we do continue according to the up-to-date. Lactation, again, the sertraline and the paroxetine is a drug of choice. And by this, I finished my lecture. Thank you very much. I hope you have get benefit from it. If you have any question, you can please ask.
Thank you very much, Dr. Wafa. Very nice lecture and elaborate presentation. We have some questions for you. At which depression severity the referral to psychiatrist is mandatory?
I didn't listen. Can you please repeat?
Yes, doctor. At which depression severity the referral to psychiatrist is mandatory?
Okay. The severe depression with I close it. Okay. The severe depression with the suicidal ideation. Patient is high risk. You have to refer the patient immediately. If the patient has suicidal ideation, this is a medical emergency, you can refer the patient immediately. And either if you start the medication, if you are thinking the patient is not responding after 3 to 4 weeks or the 6 weeks, you can refer the patient to the psychiatric hospital.
Okay, very nice, doctor. There is another question. Regarding CBT, is it effective if used alone without medication in mild severity depression?
Of course.
Okay, that's all for the question. Thank you very much, doctor. Very nice lecture and very nice and useful cases.
Thank you so much. It was my pleasure. I feel also enjoy myself. And thank you so much to give me a chance for this platform. I hope it was beneficial, because this is my true real work of all my clinical work, which I present to you today.
Yes, thank you very much, doctor. It was really useful, these cases. Thank you. So our final speaker for today is Dr. Hatem Mahmoud, consultant of internal medicine and endocrinology in Prince Mohammed bin Abdulaziz Hospital. Welcome, Dr. Hatem. Dr. Hatem will be presenting hypoglycemia in ER. Welcome, Dr. Hatem.
Okay, I'm sorry.
Assalamu alaikum wa rahmatullahi wa barakatuh. Before I start, while getting things straight, I just would like to thank the organizers for inviting me. And And the topic is actually the DKA protocol in the emergency room. So the protocols in general needs to meet the requirements for the available guidelines. And as you know, they should be straight, clear, and forward. And here in the Department of Medicine, the section of endocrinology at Pamba, we noticed that in several occasions that the management of DKA is delayed in the emergency room. And there are so many different reasons for that, but we found that the waiting for the result of the potassium is one of the main issues in the ER. And because, as you all know, the American Diabetes Association and other organizations, they recommend that you don't start the insulin infusion unless the potassium is available. Because patients with the DKA, they can present with hypokalemia, and giving the insulin in the face of high glucose will result on the influx of potassium backwards, meaning into the cells. So we were thinking of a way of, resolving that issue. And we looked into the literature, and we found that the potassium can actually be measured using the blood gas analyzers, which is usually available in the emergency room in our hospitals and other hospitals, and in the floor also. And we can get the result in 5 minutes or so. So based on that, we work on the protocol. So what I will do today is I will go over briefly over the pathophysiology of hypokalemia in DKA, and then we'll present some of the literature on the accuracy of potassium measurement. And then I will show you the DKA protocol proposal that we produce in the Department of Medicine. And we'll talk a little bit also about the IV fluids, the ringer lactate versus normal saline in the management of DKA. As the incidence of diabetes has risen over the past several decades, so too have the number of patients who present to the emergency department with diabetes-related emergencies, including diabetic ketoacidosis and hyperosmolar hyperglycemic state, the HHS. And DKA alone is responsible for more than 140,000 hospital admissions per year in the United States, with an average length of stay in the hospital of 3 to 4 days. And this number has increased by 30% over the past decade. And in 2014, the expenses or charges for DKA hospitalization amounted to $5 billion. So the emergency clinician must be prepared to identify and promptly treat these conditions, because without intervention, morbidity and mortality are high. As a matter of fact, the mortality from DKA has decreased substantially over the last few years, and it is about 1%. But of course, without treatment, the mortality is very high. So being knowledgeable about the common precipitants and rapidly identifying their presence is essential, as morbidity is primarily related to the triggering event. So beside managing the metabolic disorder, you should be very diligent at looking at a precipitant. In DKA, in 25% of the cases, you cannot find any cause, but pneumonias or infections in general, especially skin infection, abscesses, ischemia, strokes are one of the precipitants that we should really look for, because as I mentioned, this is a major reason of the mortality in DKA. So the metabolic derangement that occur in these conditions require careful treatment, but the treatment algorithm can seem overly complex, and having, as I mentioned, simplified systematic approach to patients with these conditions will improve efficiency in managing these emergencies. So potassium level is tightly controlled by different physiological and homeostatic mechanisms, and hypokalemia and hyperkalemia are reversible causes of cardiac arrhythmias. And potassium, as you know, is a major intracellular cation. And in diabetic ketoacidosis, the increased osmolality of the extracellular fluid draws water out of the cells, leading to elevation of the intracellular concentration of potassium, which in turn increases its gradient to the outside. So once it goes outside, it goes out in the urine. So proteolysis and glycogenolysis secondary to insulin deficiency also cause a flux of potassium from the intracellular into the extracellular, and potassium is then lost as a result of vomiting and ketoanion excretion. So anion excretion in the urine requires excretion of cations, and potassium and sodium are lost because of that. Osmotic diuresis is another mechanism of potassium loss. And the osmotic diuresis, of course, is because of the hyperglycemia. And the other thing also is a secondary hyperaldosteronism due to volume depletion. You know, you have a volume depletion, you have low perfusion of the kidney, you have high renin, high aldosterone, and aldosterone working in the distal tubules, absorbing the sodium and excreting the potassium, and absorbing the bicarb. While the total body potassium is depleted, patients with DKA can present with low, normal, or high potassium level. And infusion of insulin and correction of acidosis, as I mentioned, drives the potassium into the cell. And this can result in severe, life-threatening hypokalemia if the patient potassium is already low. And as I mentioned, this is one of the main reasons the management is delayed in the emergency room. And the American Diabetes Association guidelines recommend that potassium level must be measured and corrected before insulin infusion is started. And here I just have to mention that, you know, I think one of the nightmares that you don't wish for your enemy is when your DKA patient requires intubation. There is no contraindication for intubation, of course, but if you allow your patient in the emergency room untreated and you reach the point where to intubate him, then serious things can happen. And one of them, because the body is trying to compensate for the acidosis, usually the patient will come with hyperventilation, washing out the CO2. So if you attempt intubation, that moment when you give the patient a muscle relaxant or a paralytic agent to intubate him, that short moment when the breathing is stopped and the CO2 starts to rise, a precipitous drop in the pH can occur, and the patient might arrest even before the tube reaches the bifurcation of the trachea. So having said that, it doesn't mean that there is a contraindication to intubation. If the patient needs intubation, the patient needs to be intubated, but don't be the reason you intubate the patient because you are delaying the management of DKA. Okay, a delay in the initiation of insulin in DKA can cause patient condition to progress rapidly from being mild to moderate or even severe, requiring ICU admission, and that might also increase the risk of complications, as I mentioned, and prolonged hospital stay. Blood gas analyzers can produce potassium results in about 5 minutes or even less. And this, along with the location of the machine in the ER, can help initiate insulin infusion within a few minutes of DKA presentation, avoiding the unnecessary delay. So patients with DKA might at times be discharged at home within a few hours of presentation if treatment is started promptly. But generally speaking, a patient with moderate and severe DKA, of course, they need to be admitted. You cannot just send them home, but I'm talking about mild DKA. Okay, I'm just going over some of the literature here. This paper here, they found that this analyzer by the name of EPOC or EPOC from Siemens, Germany, is accurate compared to the Siemens Rapid Lab, which is the usual machine that is used in the central laboratories. And they concluded that, the authors, I mean, that the electrolytes measured by analyzers may be used for rapid measurement of the electrolytes in the ICU. Another paper here, 30 samples of blood, and they measure the potassium and other electrolytes using this type of gas analyzer. And they found that the results were accurate, reliable, and consistent. Another paper, 9,000 or over 9,000 matched pairs of blood gas analyzers and the automatic analyzer, the regular machine in the central laboratory. And again, they found a high concordance of results of electrolytes in critically ill patients. Another one, blood gas analyzers can also be used to measure other electrolytes like calcium. And this is another paper that the sodium and the potassium were measured in 200 paired samples collected from ICU patients. And here's the potassium measurement using the ABG analyzer was accurate when compared to the automated analyzer. And here in this paper, interestingly, the sodium result was not as accurate. So as you noticed, they are using blood gas analyzers, and but there are so many different blood gas analyzers. So we decided to run our own study on the analyzer that is available in our hospital. And so me and my colleagues, Dr. Yusuf, Dr. Zaid, and a bunch of good residents, we published this study, which we named the accuracy of potassium measurement using blood gas analyzer here in our hospital, Pamba. And we looked into the potassium results from 265. As a matter of fact, we collected over 600 samples. And we found that in 265 patients who were eligible among all the samples we collected, they have a venous blood gas or arterial blood gas drawn, and we compare that to the results of the potassium in the venous blood samples of the same patients done simultaneously or within 2 hours in the main laboratory downstairs. And all patients who had blood gas and venous blood drawn simultaneously or within 2 hours were eligible, irrespective of gender, age, diagnosis, and location in the hospital. And data were collected between January 2019 and June 2019, and we excluded all cases that were receiving IV fluids, diuretics, or potassium supplements. And we did that because, this exclusion, because we allowed 2 hours in the difference of collecting the samples. So we thought that the IV fluids, the diuretics, and the potassium supplements within 2 hours might change the result. So this is why we excluded these patients. And samples examined were from all different areas of the hospital, including the emergency room itself, the intensive care unit, the general floor, and all age and all diagnoses were included. This table just shows you the age distribution And as you can see that those who are less than 15 years and those above 60 years constituted most of the samples. And we used the Bland-Altman method. This is a statistical method to analyze the type of data that we collected. And we found that more than 95% of the data fell within 2 plus minus standard deviations of the mean difference, strongly suggestive of agreement between the index test, which is a gas analyzer, and the standard reference of the laboratory methods. And this graph here shows you that most of the data are collected with these two standards of deviation. And if you look here on this side, we subtracted the serum potassium from the blood gas potassium for every pair, and we plotted that against the mean, which is the serum potassium plus the blood gas potassium. And the graph is very suggestive of accuracy. And here we plotted the potassium by laboratory against potassium by blood gas analyzer. And it is showing a linear line, which is again suggestive of accuracy. So we concluded that the findings of this study support the use of point of care testing blood gas analyzer for measuring potassium when the results are needed urgently. Needed urgently, like in DKA, as I mentioned, or even during cardiac arrest, you know, when you are doing the CPR, you want to know if the patient is hypokalemic or hyperkalemic at that very moment. And so you can do the blood gas analyzer and you can get the results in 2 to 5 minutes. When measuring potassium, blood gas analyzers are as accurate as automated analyzers, and they produce results in 5 minutes or so and can be relied upon when potassium level is needed urgently, as I mentioned, and they are cost effective and may be available at the bedside. Okay. One of the limitations of our study is that the result, of course, cannot be generalized because we used a specific index machine, which is called the Cobas B221 by Roche Diagnostics, and compare that against a specific standard machine. So every institute should run a similar study to test the agreement of the machines they use. And another limitation also is that the paired samples in many patients were not taken at the same time, as we accepted up to 2 hours in between. And again, as I mentioned, we just chose that number 2 randomly. I mean, we felt that 2 hours is just more than 2 hours would be unacceptable, and even if the patient is not receiving diuretics, IV fluids, or anything else. And also assuming that the accuracy of the result is not affected by the underlying diagnosis is another limitation. So based on this study and the studies from the literature that I presented some of it, we proposed a protocol for managing the DKA in the emergency room. And the purpose of the protocol is just to start the insulin infusion within 5 minutes of presentation. So this is how the protocol looks like. And I will go over each part of it. So suspicion of DKA, and when the patient presents to the emergency room, if you suspect DKA, you obtain Accu-Chek. And if it is more than 14 millimole per liter, you obtain venous blood gas stat. And then physician should order CBC, urine analysis, the basic metabolics, ketones, cultures if the infection is suspected. Otherwise, there is no need for cultures. And obtaining ECG to see if there is any change of hyperkalemia or hypokalemia, and obtaining chest X-ray. Start normal saline 1 liter per hour for 1 hour, and then adjust accordingly. And the potassium in the venous blood gas So if the potassium in the venous blood gas is less than 3.3, we don't give the insulin, but we give the patient potassium IV, 20 milliequivalent per hour, and one dose only, and then order a venous blood gas stat for potassium and repeat that as necessary. So if you imagine just sending the blood actually downstairs to the main laboratory, waiting for half an hour, and then the result will come potassium low, and then you give the patient potassium and send the blood again, that might take 3 or 4 hours before starting the insulin. So this is the benefit of doing the potassium using the blood gas analyzer. Determine the severity of the DKA using the pH in the venous blood gas and other parameters if available. And by the way, if you suspect DKA in a patient who is non-diabetic, let us say you have a patient known to have diabetes type 1 and she's coming or he's coming with nausea, vomiting, abdominal pain, and the sugar is high, you can start the management of DKA before you get the ketones and everything else, because the management of DKA is a benign because it is composed of IV fluids and giving the patient insulin infusion. If it turns out to be another diagnosis, that you can hold the insulin and pursue the management of the other conditions. So it is a benign treatment, needs to be started right away, because the delay, as I mentioned, can lead to rapid deterioration in the patient condition. We consider the DKA mild if the pH is more than 7.3, and here no need for IV insulin. The patient can be managed by subcutaneous insulin, and there are some studies and papers on that. You don't always have to give insulin infusion for DKA. Moderate, severe, when the pH is less than 7.3. Start the IV insulin infusion. We can do either 6 units per hour or 0.1 unit per kilogram per hour, and call the IM. Call the IM, that was a requirement of the ER. They told us to write that down. Do AccuCheck every hour and follow the protocol. And when the AccuCheck dropped to less than 14 millimole per liter, we change the IV fluids to D5 normal saline and just the insulin infusion as necessary. So once we switch to D5, we don't go back to normal saline again, because if the sugar goes above 14 millimole, you adjust your insulin rather than changing the fluid back to normal saline. So we don't do back and forth changes in the IV fluids. We assess the need for bicarb, and we give it only if the pH is less than or equal to 6.9. And here I just would like to remind you that the bicarb is the only management in DKA that can precipitate cerebral edema. So we really don't give it unless it is necessary. And as a matter of fact, if the pH is 6.9 or less, and you order the bicarb and there is a delay in bringing that medicine for any reason, let us say 15, 20 minutes, during that time, do another venous blood gas and make sure that the pH is still at this level. Otherwise, you can hold giving that medicine, especially in children and young women. Check electrolytes, basic metabolic, and venous blood gas every 2 to 4 hours. And as ordered labs and other investigations results become available, review your diagnosis and the above management. So this protocol is for the emergency room. When the patient moves upstairs, we have another more detailed protocol that talks in details about the potassium and the IV fluids and interpreting the labs and all these things. So talking a little bit about the IV fluids, the fluid and insulin administration are the primary and most critical initial treatment of diabetic ketoacidosis. And while it is accepted that fluid resuscitation is a crucial factor, the exact type of fluid to be used remains controversial. But as I mentioned earlier, the American Diabetes Association in its most recent guidelines, they use the normal saline. The fluid lost in DKA is predominantly due to osmotic diuresis caused by glycosuria. And half the fluid loss in DKA is derived from the intracellular compartment and the other half from the extracellular compartment. So which fluid do we use? And as I mentioned here, the ADA recommend normal saline in patients of DKA and HHS. However, several recent smaller studies suggest that normal saline may not be the ideal fluid of choice. This study here randomized 45 patients to receive normal saline or balanced electrolyte solution. There are different types of solutions under this name. Ringer lactate is one of them. And the group that received the BAS had lower serum chloride and higher serum bicarbonate at resolution. You know, the normal saline is high in chloride. The concentration is 150 plus 153 or 154, and it can lead to hyperchloremic acidosis. Another study evaluated 23 patients who received plasma light versus saline. And the group that received the plasma light had a faster resolution of the metabolic acidosis, less hyperkalemia, and improved urine output. But there was no difference in duration of intensive care unit stay or the glycemic control. Another study performed a randomized trial comparing lactate ringer solution to normal saline in adults. And this study of 57 patients found a trend toward shorter time to venous pH normalization in the ringer lactate group compared to the normal saline group. It's 540 minutes versus 683. However, this was not statistically significant. And there was no significant difference in time to resolution of the DKA in the same study. And the authors concluded that it failed to indicate the benefit for ringer lactate. However, one has to wonder whether these trends would become significant if the study were larger. Another study, retrospective, looked at nearly 50,000 pediatric patients with DKA, 88% of whom received normal saline and 12% received either ringer lactate alone or ringer lactate and normal saline. And both groups had similar length of hospital stay at the end of the trial. And the ringer lactate group was associated with lower cost. Interestingly, the ringer lactate is more expensive than the normal saline, but the overall cost seems to be less here. And the ringer lactate group had a lower rates of cerebral edema, and I think this is very important, at 12.7 cases per 1,000 episodes compared with the normal saline group, which had 34.6 cases. If there will be any change in the future of the fluids, I think that would be the main reason, the cerebral edema, especially in children. This is another randomized trial, 15,000 patients critically ill, found that patients who received balanced crystalloid ringer lactate or BAS had a lower rate of new renal replacement therapy, persistent renal dysfunction, and death from any cause compared with those patients who received normal saline. And I think they are working on a subgroup of DKA patients in that study. This is showing you the difference between the normal saline and the ringer lactate. So for the sodium, the ringer lactate is less, 130 millimole per liter. And chloride is much less in the ringer lactate. This is why there's a difference in the incidence of hyperchloremic acidosis that we noticed in the previous studies. Potassium is 4. And I have to mention that, you know, like when you receive a patient with DKA and you still don't know his potassium situation, you know, you might feel uncomfortable giving a patient potassium while you don't know what is the status of his potassium. 4 milliequivalent per liter. Well, I mean, if the patient has hyperkalemia, let us say the patient is hyperkalemic, his potassium is 7 or 6. When you give him potassium, this is 4 milliequivalent. So his potassium is not going to go up. It's actually going to go down, but it will go slowly because you are giving a fluid that contains potassium compared to the normal saline where the potassium will comes down quickly. But if the patient is hypokalemic, then his potassium will go up. But again, it is slowly. So, I mean, you know, we know that the surgeons in general and obstetricians, they love the ringer lactate. We in medicine, we don't do that. And I am from an old school that says that ringer lactate is a fluid that is not good for health or disease. If the patient is healthy, you don't need to give him ringer lactate. And if the patient is sick, especially critically sick, you don't give him ringer lactate, because the lactate, the idea of the ringer lactate is that the lactate is metabolized aerobically to bicarb. So it basically improves the acidosis. But if the patient is critically very ill with poor perfusion, hypoxic, I mean, so you expect that lactate to increase the acidotic state, and also the presence of lactate, which is actually sodium lactate, it will interfere with the measurement of lactic acid in the blood. So we don't use ringer lactate a lot. I mean, at least back in the days. But as I show you, I mean, the recent studies are showing something opposite to what I'm saying. The pH of the normal saline is less than that of the ringer lactate, so that's in benefit or goes in favor of managing DKA with ringer lactate. And as you see, there is a difference in the cost here. Don't worry too much about that here in our hospital. This is a study prospectively that compares the effects of managing DKA with aggressive versus non-aggressive fluid repletion in 23 patients. Now, the aggressive fluid group received normal saline at a rate of 1,000 ml per hour for 4 hours, followed by normal saline at 500 ml per hour for 4 hours. And the non-aggressive group received normal saline at half the above rates, meaning that 500 ml per hour for 4 hours, followed by 250 ml for the following 4 hours. And patients in the less aggressive fluid group, interestingly, achieved a prompt and adequate recovery and maintained higher serum bicarbonate level. And I think, again, this is because of the amount of chloride that the first group received, the aggressive group. This is a supplementary notes that we wrote together, me, Dr. Yusuf, and for the protocol, the ER protocol and the other protocol for the inpatient management. Supplementary notes, this is what we wrote. The purpose of this pathway is to start the management of DKA within 5 to 10 minutes of suspicion of diagnosis of DKA in adult. So suspicion does not necessarily mean that the patient has DKA, but as I mentioned earlier, the management is rather benign, IV fluids and insulin in somebody who is diabetic with hyperglycemia, irrespective to the diagnosis. Suspicion means typical patient of type 1 diabetes who present, for example, with nausea, vomiting, abdominal pain, who missed taking his insulin. If the venous blood gas machine is not ready, then stat potassium is to be requested from the main laboratory. Notice that requesting potassium alone takes shorter time to be ready, because the potassium comes in the basic metabolic. So if you send the basic metabolic as a stat, it will take longer than asking for the potassium alone. All DKA patients need admission, irrespective to the severity of the disease. But as I mentioned earlier, that mild DKA may be sometimes they can be discharged home if they are managed properly and promptly in the emergency room. Mild DKA may be admitted to the general floor or the step down, and they can be managed by subcutaneous insulin every 3 hours or every 4 hours. And use venous blood gas result of potassium rather than waiting for the basic metabolic blood result to decide about whether to start IV insulin or not. And this algorithm helps the emergency department physician starting insulin infusion ASAP and before the patient is admitted to the hospital. This algorithm guides the management of DKA in the first hour of presentation, and if the patient is staying in the emergency department for longer than that, please refer to the DKA protocol for further guidance on IV fluids, and this is the one that we have in the floor. Guidance on the bicarbonate, I think I mentioned that. Do not use the bicarbonate unless the pH is 6.9 or less. And for the potassium replacement, potassium chloride should not normally be administered at a rate of greater than 20 millimole per hour. And white blood cell count is often raised in DKA, and antibiotics should only be administered if there is a clear evidence of infection. And here I have to say that we need to take a good history from the patient and a thorough physical examination looking for any hidden infection, especially you should look in the perineum for Fournier or anything like that, abscesses. Blood glucose more than 14 millimole per liter. If the blood glucose rises to more than 14 while the patient is on insulin infusion, do not stop the glucose, but instead adjust the insulin. To maintain the glucose level between 9 and 14 millimole per liter. Cerebral edema, very quickly. Children and adolescents are at the highest risk of cerebral edema. Consider it if the patient develops headache, if the patient develops reduced in the conscious level, if the patient develops cranial nerve pulses, and usually that happens in the first few hours of managing DKA. The first 6 to 12 hours, but we have seen it 2 to 3 days later. And usually the patient will be improving initially and the labs looking good, and then suddenly that deterioration happens. So you should think about cerebral edema. And if the suspicion is strong, you should start managing before you do any imaging study. It is diagnosed or confirms the diagnosis by CT scan. We administer IV mannitol, 100 mL of 20% over 20 minutes, or dexamethasone. Some people also use the hypertonic, the 3% hypertonic saline. Last thing, the guidelines, like any other guidelines, must be individualized to fit the clinical picture. And thank you for your attention. If you have any question, you are welcome. Or if you have any comment, I'm sure most of the audience here are either they are endocrinologists, diabetologists, or they care for diabetes somehow or another. So I'd be glad to hear your comments or if you have any question. Thank you.
Thank you very much, Dr. Hatem. Very nice approach to DKA management. We were actually honored to have you explaining DKA to us today. There are a few questions, Doctor.
Okay.
The first question, regarding the replacement of a fluid deficit, should it be done from the start of DKA or after the patient is out of DKA?
As I mentioned, the IV fluid replacement is the mainstay in managing DKA and the hyperosmolar state also. So once you receive the patient in the ER and you get his vitals, okay, suspicion DKA, HHS, start IV fluids right away.
And what about the deficit, Doctor?
Okay, the deficit usually DKA is an acute illness, and by the time the patient present to the emergency room, they usually have lost about 3 to 6 liters. Okay, while patient with hyperosmolar usually they have lost from 6 to 12 liters. So based on that, we do the replacement of the fluids. We don't like sit down and make calculations, except in children. Adults who, for example, don't have a fluid overload or conditions that predispose to that, like congestive heart failure, liver cirrhosis, or renal failure, we give them IV fluids 1,000 normal saline over 1 hour, and we continue like that. And after 4 hours, we can reduce it to 500 and then 250 and so on. So continuous clinical assessment and blood work every 2 to 4 hours. Yes.
Very nice, Doctor. There is another question. When to resume or start basal insulin injections? From the start of DKA or after the patient is out?
This is important question. I didn't mention that because the focus was just in a protocol for the emergency room to start the insulin as early as possible. That was the main purpose of the topic. But subcutaneous insulin, okay. Regarding the basal insulin, you can give the basal insulin the moment you receive the patient in the hospital, in the ER. Okay, if the patient is, for example, let's say the patient is on Detamir or Glargine. If the patient has received his insulin before he arrives to the ER, that's fine. If not, if the patient is due, you give it to him because it will help you to wean off the IV insulin infusion at the end of the day or the next day, if the patient has basal insulin. And when you switch to subcutaneous insulin, it's better to switch at the time of a meal, breakfast, for example, or lunchtime, so that the patient can receive his sub-Q insulin for the meal. And at the same time, you stop the insulin infusion. Back in the days, we used to do this like 1 hour or at least half an hour because we were using regular insulin at that time. But now with the Lispro-Glulicin and the Aspart, they are rapid. You know, they start working within 15 minutes. So you can give it, I would say, like half an hour maybe before you stop the insulin infusion. You can give the patient his sub-Q insulin.
The basal or the rapid, Doctor? The basal or the rapid?
Oh, the basal is from the day before.
Yes.
Yes, from the beginning. I mean, there's no problem. You should actually do that because, as I mentioned, it will help you to stop the insulin infusion if the patient has basal insulin because things has changed a lot. I mean, back. In the days, when the patient in the ICU and they are out of the DKA and you want to send them to the floor and then you write order for MPH at that time and the regular insulin. By the time the patient go to the floor and the nurse pick up the order and request the pharmacy to bring the medicine, the patient will be in DKA again and then they will send him back to you in the ICU. So having basal insulin on board will prevent that from happening. Giving the Aspart, the Lispro half an hour before you stop the insulin infusion will prevent the recurrence of the DKA.
Yes, Doctor. That's it for the questions. Thank you very much, Doctor. It was a really informative presentation. Thank you.
Thank you.
So at the end of our symposium today, we would like to thank our speakers for their valuable time and dedication. And thanks to Dr. Arij and all the other organizers who made this symposium the best it could be. And thanks to our host, BizLinks. Thank you for your cooperation and efforts. And to our respectful audience, thank you for your attendance and the productive discussions. Have a good day, ladies and gentlemen, and thank you very much.